Hello everybody, I'm Dr. Özmen. I would like to thank Mechanical Finder team for this wonderful opportunity to share our research today. We would like to present you our study called Effect of Cortical Bone Window Size and Position on Proximal Femur Strength, a quantitative CT-based finite element analysis. Some background on the issue. So there are a couple of ways to do biomechanical analysis. As you know, one is using cadavers. However, there are some real difficulties in getting high numbers of cadavers due to both ethical reasons and high costs. There is the option of saw bone. However, you are also limited by number usually with your funding. And also there is the question of how close are they to the reality. And the third option is finite element analysis. And here the most important thing I think is that the number of analyses you can do is not limited with your samples, it's limited by your imagination. So you can tweak a lot of things and really do very detailed analyses without increasing the costs. So what was the problem we were tackling here? So bone windows are windows opened in the patient's bone to usually take a biopsy or sometimes do the curettage and cementing as well. So they can be curative as well. They can be done for primary tumors like in simple bone cysts or complex cysts or metastatic lesions to make a diagnosis. Some things are known about the bone windows, such as their shape should be oblong and they shouldn't have corners. However, the ideal level, the ideal width, and the ideal axial placement of these windows are not known. They are usually advised to be as narrow as possible, as high as possible, as proximal as possible. However, there is no quantitative research that is agreed upon on the literature on this matter. So the process for biomechanical analysis in Mechanical Finder, as you know, is these 7 steps. It starts with segmentation, then mesh construction, setting up material properties, boundary conditions, loading conditions, ending conditions, and then finally giving everything to the solver. And our study followed this exact methodology, which I'll now cover in detail. So we started with segmentation and mesh construction. For this study, we had 2 patients. One was a 37-year-old male, and the second one was a 77-year-old female. The older lady, had a history of an osteoporotic pelvic fracture. So we segmented their CT scans like seen here, and then we created native meshes first. And these meshes contained on average 180,000 tetrahedral elements. And then we created the bone windows. So as you can see on the image on the right, the bone windows were all oblong shaped. They all had 22.5 millimeters in vertical length. However, they were different in some properties, and these properties were first of all the width. So some were 10 millimeter, 12.5 millimeter, 15 millimeter, and 17.5 millimeter in width. They had 3 different axial positions. So they had anterolateral, lateral, and posterolateral placement, and they were also made in 8 different levels. So just a quick calculation here, 2 patients times 4 different windows, 3 different axial positions, and 8 different levels. We had 192 different meshes in total for this study. And as I said, here you can see the different placements of the bone windows. So bone windows were made anterolaterally as seen on image C, posterolaterally as in image A, and direct laterally as seen in image B. The levels you can see on the image in the middle. So we started pretty close to the greater trochanter, and then the final window started below the lesser trochanter and ended below the lesser trochanter, so we covered a lot of ground here. And then it was time to set some material properties. So you can see the difference between the quality of bone between the osteoporotic and non-osteoporotic bone. The left side is the young person, and you can see very clearly the better quality of the cortices, the thicker cortices, as well as the more prominent compressive trabeculae at the femoral head. Although the range of the young modulus, as you can see from the legends on the lower right corner of each image, are pretty close to each other's range, the actual values are different between two bones. So we used the formula of the KAC to convert Hounsfield units to young moduli. So here you can see on the on image A the boundary condition, and on image B you can see the axial loading condition, and also on image C you can see the rotational loading condition. For the ending conditions, so the load started from 25 newtons and increased by 25 newtons each step. For the end conditions, we picked 5 surface cracks to stop the analysis. Drucker-Prager yield criteria for use for this analysis. These are some of our results. So some interesting things to see here. So the decrease in the femoral strength, yield strength, was similar in both osteoporotic and non-osteoporotic bone, in the sense that you can see the slopes of the fracture newtons were very similar. However, as you can see on the left hand side, the osteoporotic bone model starts from around 2250 newtons. However, this number for the non-osteoporotic bone is around 4500 newtons. However, once you get below level 3 or 4, as you can see, the fracture load decreases consistently across both models. The most important result in the study was the zones where the fractures occurred in both models. So on the right hand side you can see the osteoporotic bone is the fractures of the osteoporotic bone is represented by the red triangle, while the fractures of the non-osteoporotic bone is represented by the blue rectangle. So 17 out of 18 fractures happen in the within the rectangle, red rectangle for the osteoporotic bone, and 19 of the 20 fractures happened in the blue zone. So we called them the danger zones. And so our study revealed that the fracture risks increases with the width of the bone window and the more distal location. This is well known. This is not very exciting results. However, our study still found them, and we therefore report them. The more interesting results is once you get inside this danger zone, there is a 17 times more risk of fracture. So usually we would advise to stay above level 4, and we would advise to stay with a width equal or below 12.5 millimeters. In terms of axial placements, there were no differences between doing the bone window in the posterior lateral position, anterolateral, or direct lateral position. The decrease in the fracture load didn't differ for rotational and axial loading models. However, as you can see, the most important result of our study was the osteoporotic bone, the red triangle, pink triangle, you can say, seems to be more sensitive to the width of the window. However, the non-osteoporotic bone represented by the blue triangle seems to be sensitive to the window level. And although these results are very preliminary, we suggest that they might be a good starting point for future research, and there might be some differences in the ideal size and levels for the bone windows for young and old patients, which is not reported in the literature before. I'd like to thank again for your attention, and also we would like to have some special thanks for Luboš Rojnek from Mechanical Finder for his helps along the way. Thank you again.